Good afternoon, everyone. Wanted to call this meeting of Health and Human Services Subcommittee to order. Today, we have two agency report outs, and the first one that we'll hear is the West North Avenue Development, and we'll have Budget Analyst Patrick Frank give us that report.
Hello. I'm going to do this report a little bit differently than most of them are done. Most of our analyses are made for agencies that have been around and are known, and for people who are used to working with the agencies. This is a brand new agency that I found out about when the governor introduced the budget. And it's getting its first appropriation in 2024. So I'm going to go ahead and start in the middle of the document on page 6 to give an introduction of what the West North Avenue Development Authority is. First of all, it was established by chapters 80 and 81 of 2021, I believe it is. Its goal is to revitalize the neighborhood around the West North Avenue from this, I believe, the 600 block to the 3200 block. That's called the target area in the legislation. There's a 250-yard buffer around the target area, so it's 500 yards across. And what this is doing is supposed to help with housing, with economic development, and a broad range of services and benefits for that. For those communities, I should say. There is a board that has 15 members on it. This bulleted list shows you who is on the board. The chair of the board is the president or the designee of the president of Coppin State University, a senator, a delegate. State and Baltimore City housing departments have members on the board. There's a member appointed by the governor, by the Baltimore City mayor. And so this is kind of a broad range, and also some community associations have 2 members as well. The executive director of this new authority did talk to the Attorney General's office to get some clarification about what they are, since they're new. That it wasn't quite obvious. The Attorney General concluded that is essentially a state agency is how they would view it, because most of its money is coming from the state. And I think the phrase they used is more akin to a state agency than a local or non-government agency. As such, it requires they have to follow the state procurement law. There is some legislation that would change and add the Medco executive director or designee and change how procurement would work for this agency that has been introduced. And with that kind of a background, now I'll go back and start on the analysis. As you can see, there's just about a $11.5 million appropriation, and 2024 is the first year of the appropriation. I do want to mention that it did get 4 $250,000 grants, 2 from the city and 2 from the state, in order to get started. Let's see, the spending summary, 89% or $10 million of this agency is grants that they will be giving out. Another 10% is salaries and benefits. And finally, 1% is the other costs to run the office. And I'm going to a little bit deeper into what this is. We'll talk about the grants later, but as you can see, about $700,000 is for salaries. There is some concern that state salaries are low, so they have been given some money to reclassify positions if they are struggling to fill positions. And then you can see the other expenses there. The technical special fees are for if they need some small studies to be made. Equipment they'll need desks and things like that. So get started. The grants, the executive director with the board has determined what kinds of fund projects will be supported with the grants. And here's a list that shows how much each of these different areas are getting. As you can see, there's for an incubator for businesses, there's stuff for housing, retail, and a whole host of different kinds of grants. At this point, there are only 2 positions, the executive director and an executive assistant. The plan is to give them 7 more positions. You can see from this list here what they are. There'll be a lawyer, a planning officer, a research person. Also, then they'll have different positions that focus on things like housing, economic development, transportation. Okay, we do have a couple of recommendations that on this and a couple of small issues. First of all, as a new agency, it doesn't have any MFR yet. So we'd like to, there's some narrative asking them to put together an MFR plan. Also, the grant award process, it would be helpful if there was some documentation about how that worked. The idea here is that they would prepare, to show what the criteria are and how the process works so that they could hand out to people who would like to get a grant and things like that. So to make it more transparent and make it clear what's going on. So those are our issues that, as I understand, they don't object to any of this. This is basically straightforward, just how to run an agency kind of stuff. And there you can see the two recommendations we have, which is for the MFR and for a grants manual. And with that, I'll conclude my remarks and take questions.
Thank you, Mr. Frank. Seeing no questions at this time, we'll recognize Mr. Chad Williams.
Thank you for this opportunity to speak with you. I submitted a written testimony, so I'm just going to summarize that written testimony. The West North Avenue Development Authority, yes, was created by the Maryland General Assembly and to focus on revitalization along West North Avenue, primarily in housing, economic development, transportation, and neighborhood development. When we requested an advice and opinion letter from the Maryland Attorney General's office back in June of last year, we finally received a letter in November of last year. And there were 6 things that came out of that. The Maryland Attorney General's office determined that, yes, we were supposed to create a comprehensive plan, serve as a clearinghouse and resource center for real estate developers, business entrepreneurs that want to locate. What we've done is created a matrix of funding resources that we will eventually post on our website. Ensure that money is being spent efficiently and effectively among state and city and philanthropic partners, provide technical assistance and advisory services to the city and state, coordinate those plan and development activities. And then the biggest component is to initiate and fund development projects along West North Avenue and then operate within the appropriate budget. And so as a result of that, what the budget analyst legislative office just laid out is we came up with a list of job descriptions that aligns with the Maryland Attorney General's letter, no more than that. Obviously, in further conversations after we submitted our budget, we inferred that there would be some central activities run by the state, but that didn't become the case. And so we will use some programming money that is proposed in the funding to cover a chief financial officer that will handle budget, auditing, and HR, and then a underwriter similar to DACD uses to make a separate programmatic assessment, risk assessment of our grants. We do concur with the recommendations of the legislative department to come up with a grant manual, report that out to the committee, and also the other additional budget requirements. And I'm happy to take any questions about what the authority has been doing to get started up and where we go with the budget.
Senator Zucker.
Thank you very much, Mr. Chair. It's good to see you again.
Thank you.
When do you expect to fill the vacancies?
Well, that could be a tough question in this market. Obviously, we can't hire individuals until July 1st. We have been given special consideration to start marketing these positions. We're going through a classification period right now with Office of Personnel and Benefits. Once that's finished in the next couple of weeks, we'll post those positions and recruit to hire people to start on July 1st. However, realistically, I'm looking at fully filling these positions sometime between July and October based on the current market. I want to be very realistic about that.
Seeing no further questions, Mr. Davis, just want to just recognize your leadership. It's always good to start something from the ground up and just building something. So super encouraged about that. Also, we know the challenges that we face on our North Avenue corridor, but look forward to your leadership to make sure that we won't look like that 10, 20 years, 30 years from now. Mr. Frank, just also wanted to thank you for the due diligence in reference to the first budget report for the West North Avenue Development Authority. Colleagues, at this time, we're going to move to our second briefing for today. And we're going to ask Ms. Samantha Tapia to give us the readout for MDH Behavioral Health Administration.
Thank you, Mr. Chair and members of the committee. Just get my screen share. All right, so we're looking at again, Samantha Tapia presenting on the Behavioral Health Administration. So we're looking at a decrease of 20.1 million or 0.7% down to 2.93 billion. As you can see, BHA is generally level funded from year to year. We're going to turn to page 5 to look at managing for results data right away. Exhibit 1 on page 6 is on patient volume in the public behavioral health system, looking at individuals served. There's a downward trend in fiscal 2020 and 2021 that was reversed in 2022 with an increase of 4% in total number of individuals served. But this is only a 1.2% increase from fiscal 2019. And then the number of dually diagnosed individuals treated increased only 0.5%, and SUDS or substance use disorder diagnosed individuals treated declined a further 1.3%. So we asked BHA to discuss efforts to ensure that those with SUDS diagnosis are able to access and receive appropriate services. Looking at Exhibit 2 on page 7, looking at general mental health needs, BHA provides an estimate of the number of individuals with serious mental illness or SMI in the state. The exhibit shows the number of individuals with SMI treated in the PBHS or public behavioral health system as a percentage of that estimate. So in better news, the fiscal 2024 report shows slight improvement in the number of individuals in treatment at 1% increase for both adults and children. Looking at telebehavioral health in rural settings, Exhibit 3 on page 8, we see an increase of 30% over fiscal 2020 and 25% over fiscal 2021 during the pandemic, naturally. But in 2022, we see a decrease of over 9%, even while there was an increase in total number of individuals served in outpatient settings in rural areas. So we think that another year of data may be needed to make any suggestion about patient preferences. But again, this is only in rural jurisdictions. So we've renewed a request from the previous year for statewide data on utilization of telebehavioral health services. Moving to readmission rates, Exhibit 4 on page 10. BHA provides data on the percentage of individuals readmitted to an inpatient facility within 30 days of release from the same or another inpatient facility. The managing for results goal is that this readmission rate is under 18% for mental health cases, general mental health cases, and under 20% for substance use disorder cases. The exhibit shows that the goal has been met each year. However, the substance use disorder rate has increased each year from 11.2% in 2020 to over 18% in 2022. So we've requested BHA comment on efforts to reduce the readmission rates for SUDS patients and whether lessons applied in reducing mental health readmissions could be applied to SUDS patients, general mental health to SUDS patients. Looking at medication-assisted treatment services, Exhibit 5 on page 11. Medication-assisted treatment, or MAT, is treatment involving the regulated use of prescribed opioid-like treatment drugs that have been developed, such as buprenorphine, methadone, and naltrexone. The exhibit shows the percent of PBHS substance abuse disorder patients utilizing MAT has remained below 30% from 2020 to 2022, and that there has been a decrease of 2.2 percentage points from 2021 to 2022. So we renewed the request from last year, again, recommending a report on the availability of access to medication-assisted treatment and the distribution of medication-assisted treatment providers across the state. Moving on to, or back to the budget, looking at fiscal 2023 changes, we have a number of deficiency appropriations, 256 million for Medicaid behavioral health reimbursements, 67.5 million for non-Medicaid substance use disorder community services, and 8 million in behavioral health infrastructure investments, which is part of a pair, also an appropriation in fiscal 2024 that I'll talk about shortly. There's also some smaller deficiency appropriations for Shepherd Pratt, the Social Security Disability Benefits Outreach and Access Program, and backfill for the Mid-Shore Traffic Control Program. We also have a negative deficiency of 20.3 million due to a policy change expanding inpatient hospital service eligibility for Medicaid reimbursement. There's also an 85.6 million general fund, federal fund swap, which I will also discuss shortly. We also have a planned reversion. Under the Medicaid program, claims can be submitted up to a year after the service has been delivered. So in fiscal 2023, we have unspent funds of 70 million allocated in the budget for the purpose of Medicaid or provider reimbursements that will be reverted at the end of fiscal 2023. In fiscal 2023, we also have a block of funding of 35 million in general funds to expand crisis services, including 23-hour outpatient beds. Given the new block of funding by deficiency appropriation fiscal 2023 and 2024, the pair that I just mentioned, 8 million in fiscal 2023 and 70 million in fiscal 2024 for budget for crisis services, which we've also requested information on. We've asked BHA to discuss in more detail how this 35 million in fiscal 2023 has been being used. Moving to fiscal 2024, a general overview of spending. Medicaid provider reimbursements occupy about 3/4 of the budget, 72% for provider reimbursements or 2.1 billion. Non-Medicaid community provider reimbursements at 26% or 752 million, and the rest in 2% executive direction and for the ASO contract at 53 million. Some more specific highlights in spending. We have provider reimbursement decrease of 191.8 million, mandated increase in provider rates, 47.6 million, and the net behavioral health infrastructure investments change of 62 million. We also have the state opioid response funding at 39.5 million in federal funds, and funding for the 988 crisis line increased by 500,000 from 5 million to 5.5 million, which I'll discuss more in issue 2. Is there 191 million decrease? And then, okay. All right, looking at the issue of the behavioral health infrastructure investments, as I said, 70 million in general funds is included in the fiscal 2024 budget for the general purposes of improving crisis services, timeliness of court placement, and the issue of hospital overstays. Depending on more specific uses of the funds, we think the state may be able to supply the amount, supplement the amount with matching federal fund sources. So we recommended restricting use of the funds until a report is submitted with more specific information on the programmatic allocation and use of funds toward the previously mentioned goals. Then looking at the enhanced federal match, due to federal legislation, a phase out of the enhanced FMAP or federal medical assistance percentage provided during the pandemic will begin on April 1st. What this means for the BHA's budget is that there is a deficiency appropriation for fiscal 2023, swapping 85.6 million in general funds for federal funds. This is along with a similar swap of 17 million in fiscal 2024, which results in a positive difference of 69 million in general funds that can be used in fiscal 2024. Also impacted by the ending of the public health emergency is the general fund adequacy in fiscal 2024 for provider reimbursements. The federally mandated freeze on Medicaid disenrollments will also begin will be ending on April 1st. And based on our updated, more favorable enrollment forecast, we recommend reducing the funds provided for reimbursements by 40 million. We also recommend a reduction of 100 million total in general funds across the two reimbursement programs in the fiscal 2023 deficiency because of a budgeting error. Finally, we have the federal stimulus funds that were not recognized in the state budget. BHA was awarded 27.8 and 27.6 million each for mental health and substance abuse treatment programs, respectively, through the American Rescue Plan Act of 2021, or ARPA. Approximately 10.2 million is left over in funding from each of the grants, but has not yet been allocated in the 2024 BHA budget. So we recommended reduction in the general fund of the infrastructure improvements that were already mentioned by 20 million and replacement of those funds with the unappropriated federal block grant balances. Looking at personnel is pretty straightforward. BHA is unique this year in being below the budgeted turnover rate, only 9 vacancies, while the budgeted vacancies are 11.32. But they have 13 new, mostly administrative positions, and contractual positions reduced by 6.76 positions. Moving on to issues, we have a summary and update on the ASO recruitment and forgiveness process. As a reminder or review, the ASO was contracted in July of 2019, launched the service in January 2020 without sufficient testing, and it was nearly non-functional through August of 2020. The administration decided to estimate and pay out reimbursements during that time to support providers, leading to a large number of overpayments and a recruitment effort that started in August of 2020 and is still ongoing today. Original estimated payments were at 1.06 billion, and after some bill reconciliation, the amount to be recouped was approximately 360 million in October of 2020. It now stands at 112 million after ongoing recoupment and forgiveness efforts, which began at the end of fiscal 20, or the FIT forgiveness program, which began at the end of fiscal 2022. That program provided the option for those providers owing less than 25,000 forgiveness of their debt. And then remaining providers were given a number of different options, which are listed on page 21, including the option to pay down their debt to the 25,000 mark for forgiveness. Here's our list of options. Looking at Exhibit 8 on page 22, this shows the distribution of outstanding accounts by balance remaining, showing that most accounts have been paid or reconciled down under the 50,000 mark. Exhibit 9 on page 23 shows the decreasing outstanding overpayment debt over the past 2 years, as I already mentioned, from 360 million down to 112 million now in January 2023. The administration plans to continue recoupment and forgiveness efforts through the calendar year 2023, and then send the remaining accounts to Central Collection Unit. So we've asked we've asked for commentary on the progress of the new ASO contractor selection and what changes have been discussed and adopted for reforming the contract selection process. And we've also recommended a report on the actual or estimated status of provider recoupment and forgiveness at the close of the calendar year 2023. Moving on to the 988 crisis line. The 988 line was established by Congress as the National Suicide Hotline in October of 2020. States were given a year to coordinate state legislation and funding to support state level operation at of the national program. In Maryland, Chapter 145 and 146 of 2022 designated the 988 line as the primary suicide and behavioral health crisis hotline in Maryland and established the 988 Trust Fund to fund 988 program development and reimburse participating crisis call center and mobile crisis team providers. Exhibit 10 on page 26 shows 988 call volume for Maryland as reported by the National Suicide Prevention Lifeline since it went live in July of 2021. We can see that 988 call volume has been increasing, and data for January 2023 that's not shown in this graph reflects a further increase on December 2022. Based on the average call duration reported, the exhibit also shows a steady increase in the estimated average number of call hours handled by staff per day in a given month. $5 million was allocated to the fund for fiscal 2023 and $5.5 million for fiscal 2024, as already mentioned. BHA reports that the funds so far have been used to recruit, hire, train, and retain call center staff, coordinate response structure, and improve the call, text, and chat response rate. But we've asked BHA to comment on whether it anticipates the same or similar uses of the funding in fiscal 2024. To review the recommendations, we have several fund restrictions pending reports. The report on ASO recruitment, the repeated report on telebehavioral health utilization statewide, the access to medication-assisted treatment, and a request for the non-Medicaid public behavioral health system utilization data for fiscal 2022 through 2024 for use in our forecasting utilization for coming years. We also have the fund restriction on the 70 million that was appropriated for the behavioral health infrastructure investments, and restriction of the reimbursement funding to the reimbursement programs, the 3 reimbursement programs. And then we have the recommended reductions, 20 million for the ARPA funds, 40 million for the difference in the Medicaid enrollment forecasts, and the reduction of 100 million due to the budgeting errors. Other than that, we have a summary of the last year's JCR requests, the audit findings related to the ASO, and a update on the bed registry IT project. And other than that, we concur with the governor's budget. Thank you.
Thank you, Ms. Tapia. Seeing no questions from members of the committee at this time, I'd like to bring up the Behavioral Health Administration.
Thank you, Mr. Chairman, members of the committee. My name is Erin McMullen, and I'm the Chief of Staff at the Maryland Department of Health. Secretary Herrera Scott sends her regards. She's sorry she can't be here today, but she's with the governor. I'm also joined by Dr. Lisa Burgess. She's the Acting Deputy Secretary of the Behavioral Health Administration, and our CFO, Amelie Brandenburg. We also have staff available for questions. I just want to thank Ms. Tapia and the DLS team for this budget analysis. Before I turn it over to Dr. Burgess, I just wanted to take a minute to talk about the first prompt in the analysis, which was about the larger vision for the public behavioral health system, and then access to substance use treatment in particular. So it's no surprise probably to this committee that the COVID-19 pandemic exacerbated mental health and substance use disorder crises here in the state. While this increase in disease burden is concerning, it has provided an opportunity for both the administration and the General Assembly to address these long stigmatized health problems and hopefully seek out some solutions to strengthen our behavioral health continuum of care. We do want to acknowledge that we really do need to take a lot of steps to improve access to both substance use disorder treatment and mental health treatment in our state. Nationally, we know that less than 15% of people with substance use disorders receive any treatment. We also know that gaps exist for people with mental health conditions. Less than 50% of individuals with mental illness are accessing treatment in a given year. These treatment gaps are frankly just unacceptable, and we can do better. Marylanders with behavioral health conditions shouldn't be left behind. The department is committed to working to strengthen the behavioral health continuum of care in our state. And we're also working to make sure that individuals with these conditions can access our public behavioral health system through multiple different entry points. 988 was mentioned earlier, and its 8 crisis call centers. Those are key to supporting our continuum of care. We're also expanding mobile crisis services through Medicaid on July 1st. And then we're also increasing crisis stabilization centers, those 23-hour beds that the analyst mentioned. There's also examples of our approach, which can be found in the 24 state opioid response initiatives. And with that, I'll turn it over to Dr. Burgess to walk through the summary of our response to the DLS analysis.
Thank you, Anna. So firstly, regarding the statewide data collection and reporting on PBS, on the public behavioral health systems, telebehavioral health utilization, we will get that report to you. My apologies for you not having it yet. We'd be happy to. Regarding the reduction of readmissions for SUD patients and whether lessons applied in reducing mental health readmissions, we appreciate that observation, and we agree that this is an opportunity to learn from the decreased readmissions seen in the mental health service line. So for example, we have a pilot program called the Maryland Readmission Reduction Program. It's in 5 jurisdictions. That program identifies individuals who have a mental health diagnosis and who also may have increased admissions to the emergency departments. Care coordinators are deployed to the hospitals, whether it's the inpatient unit or the emergency department, and those transition workers engage the patients that are being discharged into the community. This increases the chance that individuals are not lost to follow-up. So with that as an example, we have state care coordinating programs. And this program deploys care coordinators into high-intensity SUD or substance use disorder treatment programs. They meet the patients, they transition them into the community, again, increasing the chance that these individuals are not lost to follow-up. I have 2 more examples. In July of this year, peer services will be reimbursed in certain SUD settings. And among the many items that the peers focus on is care coordination. And so assisting individuals into having community support will again support the decrease in readmissions of individuals who have SUD diagnosis. Lastly, with expansion of crisis services, we now reimburse for individuals who have crises associated with opioids and stimulants. Also, SBIRT, which stands for screening, brief intervention, and referral to treatment, will be reimbursed in crisis services. So again, thank you so much for that observation. We do plan on evaluating the lessons learned from the decrease in readmissions for those individuals who have a diagnosis of mental health. And with that, I will turn it over to Emily Braden.
Thank you, Dr. Burgess. I'm going to follow along in the analysis for our responses. We were asked to comment specifically how we're using the $35 million budgeted in 23 to support crisis response efforts. In 23, the department was focused on developing the requirements and regulations for mobile crisis services and crisis stabilization centers. This work took us longer than we anticipated, and to date, we have not spent the funding. We did want to note we're still working through our second quarter projection and confirming if part or all or any of the $35 million might be needed to close BHA. DLS made a recommendation to restrict use of $50 million of our $75 million included for the behavioral health investment pending a submission of report. We wanted to let this committee know we've gone through the work. We have a plan, a detailed plan which meets most of the requirements of the report. Right now, we're working through Department of Budget Management and the governor's office, but what we'd like to do is share it both with this committee and DLS way before the July 1st reporting date that was suggested. So as such, we were hoping not to do a report, but rather have a conversation and get this process moving. We also had a recommendation because of a favorable enrollment forecast, a $40 million general fund reduction to our Medicaid behavioral health budget. We respectfully disagree with the recommendation of a $40 million general fund reduction. This is a really unusual time for enrollment projections. You have the Family First Coronavirus Response Act with the continuous enrollment ending in the next 6 months. It's really, really difficult. However, what we would like to do is work with our partners, both at DBM and DLS, together and see if there's a reduction that's palatable for all parties. So we're not suggesting no, we're just suggesting 40 is probably not where we can be. And we were also wanted to talk about the reducing general funds budgeted for our infrastructure improvements by 20 million and authorizing MDH to replace these funds with unappropriated federal block grants from ARPA. So this one, there's again, the department respectfully disagrees. The ARPA funds have already been approved, budgeted, and the plan was submitted to the U.S. Substance Abuse and Mental Health Service Administration, or SAMHSA. And any changes must also be approved by SAMHSA. The plan approved includes awards to local jurisdictions, 211 Maryland, and specific providers in both 23 and 24 to address state priorities for mental health and substance use disorders. Maryland's budget and spend plan was developing following federal guidance, and local jurisdictions and other grantees have already received their proposed allocations for 23. And right now, BHA is currently reviewing the 24 spend plans. It's important to note in this as well, some projects would continue in 24 that started in 23. So any funding diverted from the General Assembly could halt or jeopardize these projects already in place. And we were asked to provide reports on actual or estimated status of provider recoupment and forgiveness, the close of the calendar year 23, and we agree, and we're happy to provide that information.
So then update on the progress of the new ASO contractor and changes. So the RFP was posted on eMaryland Marketplace Advantage. It closes on March the 16th. After the solicitation end date, we anticipate reviewing the RFP responses. We do have two guiding principles. I will highlight them, and that is to ensure prompt payment of valid claims and also to have an expanding reporting, and that includes the data sharing will occur with the MCOs, and there will be auditing of performance and quality assurance activities. Regarding the operational differences between 211 and 988. So certainly 988 and 211 share the mission of meeting the needs of individuals who have mental health and substance use disorder associated crises. 988 became live in July of 2022. And it's a national line, of course, in 211 Maryland. On the other hand, started 3 years ago. 988 is vital to the crisis system. It's not uncommon that that's the front door to the crisis system. 211, while servicing as a crisis line, also transitions individuals into access to a statewide resource directory and referral to social needs or social determinants of health. In addition, 211 Press 4 is our bed registry. And this bed registry is an inpatient psychiatry, inpatient bed locator. And it also assists with care coordination. So again, both lines are involved in crisis services. We are transitioning to 988, the national line, while 211 functions with assisting individuals in accessing social supports. And then we're to report on whether we anticipate similar uses for the fiscal 2024 funding. Yes, we do. We do anticipate that these funds will be utilized to recruit, hire, train, retain call center specialists. We want this workforce to staff the local 988 Lifeline crisis centers. So with that, I thank you very much for your attention, and we're happy to take your questions.
Thank you. Just a couple questions, and I want to make sure that some of the written testimony that those you'll be able to comment on that. But one you talked about guiding principles for the RFP that's being placed for the ASO. But could you just Is one of the guiding principles in reference to past experiences? Is I guess one of the questions that I have.
So I'll start off and then I will let Aaron. So one, I'm not on the committee, but I can tell you, being at MDH, yes, sir, we have absolutely learned from that experience. It was a painful experience, and we regret that experience, but we, on the other hand, have learned from it. And since the two guiding principles, there are others that we've learned from. We need a longer runway for them to come back into the state, but certainly to your question, yes.
Thank you. One of the questions in the written statements, there was some level of concern from Johns Hopkins. They encouraged the 211 press force system. If you wanted to just kind of comment if that's been brought to your attention, I guess it's a service that was already offered, but may not be at the same capacity at this moment.
So I'm happy to respond to that. Mr. Chair, would you please just repeat that one more time for me so I can make sure I'm.
So it reads, finally, we encourage a review of the 211 press force system. In 2021, law established the Maryland Mental Health Substance Use Disorder Registry and Referral System to provide a statewide system through which healthcare providers can identify and access available inpatient. And they went on and on and on in reference to that piece of it, but I wanted to give you all the opportunity to comment.
It exists, and we are doing our best to ensure that our providers know about it.
Mm-hmm.
The lead is Marshall Henson behind me. We are really excited about our hospitals being involved in accessing that service so that they will have the opportunity to receive support when looking for dispositions for their patients.
Yes, ma'am. And the next question just comes from Community Behavioral Health. And they talked about language in the 2021 budget required by Maryland Department of Health that wasn't being followed, where MDH failed to comply to hire an independent entity to mediate between providers and Optum on disputed claims. If you wanted to just comment.
I will probably need to get back with you on that response, Senator McRae.
Yes, ma'am. And then there were several in reference to the 988, just appropriating more dollars. Obviously, we took care of that for the next fiscal years with Senate Bill 3. But if you wanted to comment on this specific budget.
Want to thank you. We are so excited about the support that Maryland is showing for that. Again, it's not uncommon that 988, somewhere to call, someone to respond, and somewhere to go, that 988 is not uncommon, the first entry into the crisis system. So we just want to voice our appreciation for the support that you've given it.
Yeah, the only thing I would add is that the secretary and the administration are really committed to seeking out federal funding where we can to help support these things. And some other states have started to do some creative things in their Medicaid program to try to seek out funding in this space. So I think in the interim, we're going to try to look at and see how we can continue to support our continuum, including 988 with federal money.
Thank you, Senator Hedelman.
Thank you very much, Mr. Chairman. I just want to follow up a little bit to get a better sense on the ASO RFP process. You said that it is closes, I guess, in 2 weeks. Do you have any sense of whether there are a number of options available? Is that something that you can share with us now, and kind of what the timeline is to make that decision?
So I'm not able to share that information with you, but I can get back with our leadership and see what response, if at all, that I can forward.
Okay, I guess I'd just like to also reiterate what the chair began to discuss, which is the concerns that we have heard from so many community service organizations and who have struggled and really had difficulties over these past couple of years. And I really would hope that those experiences and those challenges would be really seriously considered in the awarding of a new contract. So I'll just leave it there. I also have another question, and you tell me if this is not appropriate for this department, but I read recently about, it seems like it would have some overlap, but the Banner recently had an article about a program called ACIS. Are you familiar with that?
I'm not.
Okay. It is to help people who are homeless stay in the community. It was a partnership along with the department and a number of hospitals that pitched in funding to really do intensive case management and in Baltimore, and has at least an initial research seems to indicate a great deal of success. And so I'm just curious, and you can tell me if that's not your department, but it seems like it certainly has some overlap with mental health, behavioral health. And if I need to ask someone else, I'm happy to do that.
Yeah, no, that is definitely us.
Okay.
It's in the Medicaid budget at the agency. If you'd like, we can follow up and share some additional information on the program and just how it works and how we're thinking about expanding.
That would be great, because my understanding is it comes to an end, and at least the initial reporting seems to indicate it's been quite successful. And so I would hate for that to go by the wayside.
Yeah, we'll definitely get back to you on details of
Appreciate it.
that.
Thank you very much.
Senator Zucker. Okay, perfect. To the agency, just look forward to following back up in reference to the 211 press score system, because obviously they're saying that it doesn't work in the capacity that it should work in. And also in reference to the community behavioral health organization that talked about the independent folks that's supposed to be facilitating the negotiations would definitely be helpful, and the committee has some level of an interest. So if you can get back with Ms. Tapia, that would be very, very helpful. I also wanted to lean in and just say thank you all for the important work that you do each and every day for Marylanders across the state. Colleagues, at this time, this ends the agency part of it, but we do have a number of folks that want to give public testimony. I'm going to ask that we limit the testimony to 2 minutes if possible. And the first person I'd like to bring up is the organization CBH, but my good friend, Miss Lori Doyle.
Thank you, Mr. Chairman. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. Today, unfortunately, though, I'm playing the role of canary in the mine shaft to relay to you that we're seeing a level of financial distress in our organizations that we have not seen before. And these are longtime providers with very sound fiscal management practices, quality services, and they're looking at significant program closures and layoffs. And it's all due to the pandemic, yes, but Optum. They can't survive this 1-2 punch. So we're paying back money now, money that we may not even owe, because Optum can't show us whether we owe it or not. And that's where the independent mediator comes in, somebody to say, yeah, you owe this money. No, you don't owe that. It's a mess and we can't get to the bottom of it. We're also paying, providers are having their claims clipped for services that they're providing now. And they're going to face balloon payments at the end of this year. And that's coming up in, I guess, about September. Anything they owe, they have to pay or they'll be turned over to collections. And there are some significant amounts of money that are owed right now, and we're worried about it. So beyond the independent mediator, we do have a couple of asks around the budget and around support for our behavioral health providers. One is in reference to the Fight for 15 that you all passed in 2019, the minimum wage bill. And we thank you for the increases, the mandates that you put in from FY21 through FY26 for behavioral health, for developmental disabilities, and for long-term care providers. FY24's increase was to be 4% for long-term care and developmental disabilities, but only 3% for behavioral health for no particular reason. Governor Moore's budget accelerates FY25 and 26 rate increases, which are 4% for all of us, to July 1 of this year. Contingent, of course, upon passage of the Fair Wage Act. So 8% will be added to what we were slated for in FY24. That results in long-term care and DD providers receiving 12%, but behavioral health receiving 11%. We've written to the governor asking for a 1% supplemental to provide parity with the other two groups. And it's really not so much around parity, it's around we're suffering. We are hurting. We have a workforce problem, and we love our colleagues in our other areas, but we're all competing for this same workforce. If we're turned down, we urge this committee to use the $70 million in discretionary funds in the BHA budget for that purpose. May I ask one more. Thank you. Thank you for your indulgence, Mr. Chairman. Finally, we ask that you resist any effort to delay the rate increase beyond July 1 of this year. It's tied to the Fair Wage Act, yes, but the reality is that our rates cover everything. So gas, food, rents, all of that. And of course, inflation has hit them all. There's no negotiating on those costs. So we'll end up cutting the only discretionary line item we have, which is wages and benefits, which is exactly where we don't want to go. So thank you for your time. Appreciate it.
Yes, ma'am. We hear you very loud and clear.
Thank you.
The second person that we'd like to bring up at this time is Nikita Sharma from Be More Clubhouse.
Good afternoon, and thank you for the opportunity to testify today. My name is Nikita Sharma, and I'm here to represent Be More Clubhouse. We work with adults experiencing serious and persistent mental illness in Baltimore City and are the only clubhouse in Maryland. The clubhouse model that we follow is all about people, place, and purpose, an integrative psychosocial approach to recovery. Combined with clinical services, the outcomes are reduced hospitalization and public mental health cost and improved long-term recovery. On a daily basis, we utilize an accredited evidence-based model that makes use of a work-ordered day where our members that are our program participants operate and manage the program with strong peer-to-peer support. Members receive the opportunity and tools to feel empowered and work actively on goals including employment, education, or housing. Most importantly, the strength-based method helps our members gain a sense of purpose and self as they navigate living with mental illness. The reason I have so much faith and passion in the clubhouse model is because of the times I have been proven wrong. When new members join, my doubts and biases creep in at times. But I see individuals build their lives and become leaders in clubhouse operation or in the community. It's just amazing to see how as humans can do so much when we have the right type of support system, no matter what our diagnosis is. Our organization is in full support of the Behavioral Health Administration's budget for fiscal year 2024. We're pleased that the administration is providing increased support for community-based behavioral health programming. Be More Clubhouse has previously received BHA funding, and we look forward to working with them again moving forward. It is our hope that we can partner with BHA and elected officials across Maryland to create community and opportunities for individuals living with mental illness by supporting Be More Clubhouse and the expansion of the clubhouse model in our state. Thank you.
Thank you. I just wanted to make sure that brought some of the things up from the agency standpoint. So I know that you all bill a certain way, but other models and other states bill in a different way. If you could just elaborate on that.
Yeah, so right now we have the PRP, Psychiatric Rehabilitation Services license to bill Medicaid, but it's not really the right fit of our model because it takes away important components of the program, which is providing autonomy for our members, but having to go the clinical route kind of takes away from the program and its efficacy. So we want to explore funding ways in which clubhouses are funded independently or see other ways that could work.
Thank you. And I guess to the agency, I did have an interest in just better understanding the different models of the funding models and being able to understand why we didn't do it. So thank you. And the next person that we'll bring up is Ms. Vicki Walters from the Maryland Association for Treatment Opioid Dependence.
She had some family issues come up today and sorry she can't be here.
Yes, ma'am. At this time, we'll bring up Ms. Kim Wireman from the Maryland Addiction Directors Council.
Actually, I'm in her place instead. Thank you. Right? Is that okay?
Okay, no problem.
Oh,
Please.
sorry. Hi, Senator McCray.
Just please state your name for the record.
Craig Lippens. I am the president of the Maryland Addiction Directors Council. We are a provider association with over 1,500 substance use disorders and dual recovery residential treatment beds, as well as a full continuum of outpatient substance use disorder treatment services and behavioral health care services all across the state. On behalf of MADC, I'm testifying in support of the governor's budget and extend our congratulations to the new secretary and the new administration. Madsey thanks the governor for including in the budget the 3% increase in the rates as directed by the Fight for 15 Act in 2019. We're appreciative that the additional 8% increase is available in the budget contingent on the passing of the Fair Wage Act. Madsey supports the much needed funding rate increases to assist with the governor's accelerated minimum wage to $15. Typically, our staff costs are about 65% of our expenses, which makes the additional funding from the state critical for the implementation of the accelerated minimum wage. With the fentanyl epidemic, lethality has soared, and clients are coming to treatment with tremendous needs. Approximately 950 people each year are dying over the last 5 years in Baltimore City alone from fentanyl overdoses. There's a looming threat as well of other emerging drugs such as xylazine, and we need to make sure that all levels of treatment are available to those that seek help. Madsey thanks the governor for the funding in the budget for crisis stabilization in 988 to provide crisis services and interventions that can save lives. Madsey strongly supports continuing accountability for Optum as providers continue to sort through claims from 2020, 2021, and 2022 due to the system failure. Madsey members also support the continued use of telehealth. Telehealth allows for members to make services needed for clients, makes them available, removes a lot of unnecessary barriers that may have made treatment inaccessible or difficult for people to attend. Thank you for the opportunity to testify and for Madsey to be represented here.
Thank you. Seeing no questions, colleagues, at this time, we're going to bring up Ms. Ann Seacott.
Thank you, Mr. Chairman, members of the committee. For the record, Ann Seacott, representing the National Council on Alcoholism and Drug Dependence, the Maryland chapter, and very red-faced for the second time messing up the sign up in this subcommittee. I got to double check the couple of hearings that are left, so I apologize. Just want to say that we are here supporting the governor's budget. We're very pleased with the rate increase that's built in, the contingent rate increase built in if the Fair Wage Act passes. I want to, acknowledge that we are so looking forward to working with the new administration on all parts of these issues. We talk a lot about crisis services. We need to, but we need to remember there's prevention, there's harm reduction, there's long-term recovery supports, as well as the treatment and the crisis interventions. It's a lot that the Behavioral Health Administration does, and we are very excited to work with them on maybe restructuring, reimagining some pieces of that. Just because it came up, I do want to acknowledge Senator Hedelman, that ACEs program that you mentioned, Healthcare for the Homeless, which is another client of mine, is very involved in that. And we'd love to talk to you more about how we can figure out how to make sure that that gets funded, because that does help keep people housed, people with mental health and substance use problems. It keeps them in their homes. Thank you.
And thank you, Ms. Seacott. At this time, I'd like to bring up Dan Martin from the Mental Health Association of Maryland. Oh, no problem at all. Ms. Seacott, that wasn't you, was it? I'm messing with you.
At that time.
At this time, I'd like to bring up Ms. Michelle Livshin on our own of Maryland Inc.
Thank you, Mr. Chairman and committee members, and thank you to the administration for all of your efforts to improve services for Marylanders. I'm Michelle Livshin, Director of Network and Peer Empowerment of On Our Own of Maryland. We're a behavioral health education and advocacy organization of peers, people with lived experience of mental health and substance use challenges. Our network of over 20 affiliated peer-run wellness and recovery centers, funded through annual BHA grant contracts, offer free walk-in recovery support services to more than 6,500 Marylanders each year. We are here in support of BHA's proposed FY24 budget and would like to thank the legislature for the increase in provider rates, which include our centers. For decades, our independent peer-run centers have been able to successfully reach community members with the greatest unmet needs, many of whom are unhoused, uninsured, and experience significant behavioral health challenges. At every center in our network, anyone can get one-on-one peer support in groups, self-help tools, health education, and feel a sense of belonging that can literally mean the difference between life and death. Centers in our network achieve incredible outcomes despite operating on median budgets of less than $150,000 per year. Our peer-driven programs deliver services that meet the unique needs of their local communities, from support accessing and navigating essential services to reentry services to peer workforce training, meal deliveries, and housing support. We can be so innovative, flexible, and responsive because of the annualized funding we receive through BHA. Peer support specialists are an integral component of the continuum of behavioral health care. We must continue to protect robust investment through grants for peer-led programs like ours that are able to reach individuals and communities most in need and which cannot manage the complexity and unpredictability of the billing through the fee-for-service system. Now is the ideal time to invest in grant-funded peer-run programs, not only because of the essential support we provide, but because we are training the next generation of certified peer recovery specialists and community leaders. Our peer network is ready to support our communities through this behavioral health crisis, but we must have the adequate resources and funding. We strongly urge the committee to vote in favor of the FY24 budget. Thank you.
And thank you. Colleagues, seeing no questions, I'd like to bring up the next public testimony, which will be from Dan Rabbit at BHSB.
Hello, Mr. Chairman, members of the committee. For the record, my name is Dan Rabbit. I am a policy director at Behavioral Health System Baltimore. We are the local behavioral health authority for Baltimore City and helped to convene a coalition called the Fund Maryland 988 campaign of over 70 organizations that's committed to investing in the 988 network here in Maryland. We fully support the governor's BHA budget. And I wanted to just expound upon our request to increase the investment into 988. First, thank you all so much for the unanimous support on SB3. We think that that's going to really help us in future years. But like the chair said, that is for FY25. In FY24, the funding level is $5.5 million for the 988 trust fund, which is only $500,000 more than FY23. We think that this needs to be increased in order to prepare for what we think is going to be a continued increase in the use of 988. We think that $12 million that was in SB3 would be an appropriate funding amount for FY24 as well. To the department's comment around federal funding, we absolutely think that federal funding can be a part of the solution here, but it is not going to add up to the amount of funding that we will need. To date, I think the department's only gotten $2.8 million over 2 years, and that's great, but that's not going to meet the needs of the network. What we're seeing is a steady increase. We've seen almost a doubling in contacts to 988 over the last year, and this is for a couple of reasons. One is people are learning more about it. We're also seeing promotional campaigns start, both the state, us here in Baltimore, as well as the federal government are all starting marketing campaigns, and that's going to lead to an increased use of 988, which is what we want. Another reason why what we're seeing an increase is because people are really hurting. I don't know if you all have seen the CDC report that just came out on youth mental health, but the statistics are striking. 30% of female high schoolers have seriously thought about suicide. That's just off the charts from where it was 10 years ago. And that's just one example, but the examples of poor mental health are all around us. So we really want to see 988 be a part of the solution to this poor mental health that we're seeing in our communities, but we need to make sure that there's someone there to answer. And we think that an increase beyond the 5.5 million that's currently in the budget is needed to ensure that. Thank you.
And thank you, Mr. Rabbit. Seeing no further questions from committee members, I just wanted to lean in and just thank you, Ms. Tapia, for the work that you do in reference to the comprehensive analysis and colleagues. That ends the hearings for HHS and look forward to seeing each and everybody Monday.